Okay, students, so let us discuss the topic trochanteric bursitis. So, trochanteric, it is associated with the greater trochanter, the hip joint, the femur bone, and bursitis, as the name suggests, is the inflammation of a bursa. So, let's see what happens actually in this condition. So, trochanteric bursitis, it is an inflammation of the bursa. The fact it's a bursitis implicates that it has an inflammatory component, itis. And we have to take into account that three of the four elements of an inflammation named rubricular tumor aren't present here. Only the pain is present. It is an element of the greater term hip bursitis that envelops four different types, mainly the trochanteric bursitis, the iliopsoas bursitis, gluteal bursitis, and the ischial bursitis. And most commonly, it results from the friction of the overlying iliotibial band. So, what is a bursa? Actually, it is a double-membraned fluid, sac containing fluid, mainly synovial fluid, and which role or which functions is to reduce the friction between the tissues. It forms a sort of cushion between the bones and the muscles, and it acts as a shock absorber and lubricant during the movement of muscles and the joints. So here in this picture, you can see the inflamed trochanteric bursa here. You can see this muscle, femur bone, and since it is inflamed here, it is the bursitis of the hip. The mechanism of injury or the pathological process. First, the bursa gets inflamed, it swells, develops friction, and starts irritating the muscle tendon. It is supposed to protect. The main function normally it is to protect the muscle tendon and reduce the friction. But when it is irritated or inflamed, it in turn irritates the muscle tendon. This way, the bursa and the muscle tendon get more and more irritated and leading to bursitis and sometimes tendinitis. Causes are overuse of the joint, repetitive strain, trauma, pressure, bacterial infection, other inflammatory disease. So here in this picture you can see this is the ilium bone, the femur bone here. This is the gluteus medius muscle coming down, and this is the iliotibial band continuing from this portion, and you have a deep trochanteric bursa here, that is the blue color at the just top of the trochanter, and also you have the trochanteric bursa which lies just covering the greater trochanter and in the beneath the iliotibial band from the gluteus medius muscle. So the first one is the subgluteus medius bursa. The bursa is located above the greater trochanter, lies in underneath the insertion of gluteus medius. Second is the subgluteus maximus bursa, between the greater trochanter and the insertion of the gluteus medius and maximus muscle. Also here you can see the ischium bone. Here also we have a bursa, the ischial bursa, and this is the iliopsoas bursa. The etiology, if you see, there are two types. One is the acute, other one is the chronic. The acute arises because of the trauma or the massive overload. After a few days, symptoms like pain, swelling, and a warm feeling is there when you touch the affected area, and also very painful. Second one is chronic, which is caused by overuse, too much pressure on the structures, or by extreme movements. Wrong muscle strain can also be a cause of the chronic bursitis, and the main symptom is always pain. There are many factors that may cause trochanteric bursitis. Men and women, if you see the ratio, women are more commonly or more affected. Overweight is one of the cause. Trauma, example, injury of the greater trochanter, this can deface the bursa. Overuse of the muscles around the bursa or the joint underneath the bursa. Incorrect position like these can cause increased pressure. too much of pressure on the bursa caused by friction of the ITB, the tight structures, dysfunction of the insertion of gluteus medius muscle, hip osteoarthritis, lumbar spondylosis because of the biomechanical alterations and other structures becoming tight, or excessive or relatively increased mileage. And then you have the repetitive strain. Example, frequent training with too much weight or training in a bad posture or bad position or wrong ergonomics. Poorly cushioned shoes. If the shoe footwear is not correct, it is another cause of the increased pressure on the muscle joints and the bursa. Excessive pronation, extreme movement, the leg length differences, the iliotibial band syndrome, bacterial infection, the inflammatory disease, also because of the hip prosthesis. The clinical presentation of the condition is chronic pain or hip tenderness in the lateral aspect of the hip that may radiate down the thigh. Then, more specifically, while palpating superior and posterior part of the greater trochanter, there will be pain. There will be tenderness maximum at the insertion of the gluteus maximus muscle. Also can be felt over the iliotibial tract. The pain limits the strength and makes the legs feel weak. Pain in the area of the greater trochanter while walking or running. Then stair climbing or climbing down is painful. Patient is not able to lie down on the affected side. Development of pain related sleep disturbances is also seen. Lower back pain can be related to trochanteric bursitis, as I said, because of the related biomechanical alterations or because of the pain. The kinetic chain is impaired. Weakness of the hip abductors. Resistance test can cause tenderness. Now, pain and tenderness can arise while resisting the movement, that is the external rotation of the hip. A snap can be felt in the lateral aspect of the hip. In differential diagnosis, we have to rule out other associated problems or other problems which may mimic same type of the symptoms. So a lot of factors have been associated, including leg length difference, as I said, excessive foot pronation, a wider pelvis, because of which women are more affected. Then trochanteric bursitis is more present in the women, as I said now, and it is frequently associated with mechanical back strain and obesity. Other pathologies are like contusion of the iliac crest or avulsions or fractures of the lateral hip, then iliotibial band syndrome, snapping hip syndrome, gluteus medius tendon dysfunction and tears, and meralgia paresthesia, that is the entrapment of the lateral cutaneous nerve. A diagnostic test for lateral hip pain, particularly for trochanteric bursitis, is without a doubt is good palpation. When you palpate, you can find the tenderness and the pain area, localized pain over the outer aspect of the hip over the greater trochanter. The most provocative clinical test is done that is by palpation. Additionally, we can do an Ober's test which is related to this, and when we do this Ober's test, as we know, when we uh, abduct the hip and put into slight extension. Here in this picture you can see the knee is flexed, but we can also do in the knee extended position. In knee extended, the ITB band is fully stretched, actually it is better, and then you slightly bring down the knee in that position down, touching the other leg. If it is touching smoothly, that is negative. If it is not possible or it is restricting or the limb is in the air, then it is a positive because of the tight structures, and which is may be responsible for the bursitis. Then the outcome measures, few measures we have like scale, the VAS scale for pain, international hip outcome tool, osteoarthritis disability index, that is the index of there are many components which will see the disability level or the interference in the daily activities. Harris hip score, 6-minute walk test, the person is allowed to walk 6 minutes, and then he is tested, or the time and the distance is measured Then in 6 minutes, what is the distance covered by the person, what is the pain level, and if the pain is more or if the pain is restricting, he may not be able to walk. Then the hip disability and osteoarthritis outcome score, then Copenhagen's hip and groin outcome score are few of the outcome measures. Physical examination is very important and must have a stepwise approach which includes inspection, the gait, the palpation, range of motion, muscle strength, and execution of the special tests. The first part is inspection. Most important aspect of inspection is the patient's posture in a seated and uprighted, how he is sitting and how he is standing. If there is an irritated hip or painful condition like the bursitis, the patient will tend to stand with the joint slightly flexed. So that will be an alteration in his posture. And in the seated position, if there is a pain, then he will be slouching and leaning to the uninvolved side, which it is obvious by his posture. So this observation is also focused on the asymmetry, the gross atrophy, spinal alignment, or the pelvic alignment. While observing the gait, we should look at the leg length discrepancy. If there is any limb length discrepancy or shortening or lengthening, whatever, there may be weakness in the and also we should see the heel strike, which contributes to the function of the gluteus maximus. The bursa pain may be detected by palpation, which starts with joint tenderness on the proximal and the distal area of the hip. It is important to check the lumbar spine. As I told you, there may be a radiating or because of the biomechanical alterations of the lumbar back pain, sacroiliac joints. If there is any sacroiliac malalignment or the iliac crest, the ischium, the lateral aspect of the greater trochanter, the muscle bellies, pubic symbiosis, they determine a potential source of hip symptoms or pain. The muscle strength can be assessed by resisted contraction which provokes symptoms. So if we resist the contraction or the movement, it will provoke the pain. So the range of motion should be checked on the actual injured hip, as well as we should compare on the sound side, that is the contralateral hip which is not affected. So an active hip flexion, an internal and external rotation, abduction adduction will reproduce pain in the injured area in the affected side. The range of motion can be identified with several tests like the Faber test, Tendelberg test, Ober's test as we have discussed now, Thomas test, and by the force flexion combined with internal rotation could be helpful in diagnosing the cause of lateral hip pain. Now coming to the medical management, first we let us look at the non-surgical treatment. If it is an aseptic trochanteric bursitis, it is treated without surgery. And if the pain results from overuse, it is recommended to reduce the activities or change the way of doing them. And a good physiotherapy rehab program comprising of stretching and strengthening will help to bring back the full range of motion in the hip, sometimes in combination with the anti-inflammatory medications or also heat and ice cryotherapy to tackle the inflammation. Improving the strength and coordination in the buttock and hip muscles also enable the femur to move in the socket smoothly and can help to reduce friction on the bursa. In this picture, you can see there are some of the basic rehab exercises. The first is the gluteal stretch, or the also you can say the piriformis stretch, and then this is the straight leg raising. This is the iliotibial band self stretching, that is by standing, crossing the leg, and by these wall leaning stretch. Then you have the prone hip extension, side lying leg lift and calm exercise. Here we the person is in side lying and trying to abduct the limb above here, abduct and bring it down. Then this is the wall squat with a ball, gym ball, and these are the planks, side planks, and the prone on elbows plank. This picture is taken from the Summit Health Management website, and in case of septic trochanteric bursitis, which is because of some infection, Further examination of the bursa fluid is necessary in the laboratory for the to know the exact bacteria so that antibiotic therapy can be prescribed. Then the surgical treatment is indicated when the non-surgical or the conservative therapy or treatment fails, and when the pain is still unbearable. And the aim of surgery is to remove the thickened bursa and the bone spurs that have arisen on the greater trochanter. Also, the large tendon of the gluteus maximus is also treated, and some surgeons prefer to remove a part of the tendon that rubs against the greater trochanter, while others prefer to lengthen the tendon to some extent. This is a picture of these injection performed under ultrasound guidance into the bursa, and also to look for whether the bursal swelling is present. Equally important, the deeper lying abductor tendons, which can be also inspected for any kind of damage. Tendon damage often uh, overlaps or covers the bursitis, or it is closely associated with bursitis. This is another picture showing you the surgical bursectomy by an arthroscope. When used outside the joint, it is termed as endoscopic procedure. The bursa can be excised and the other structures contained within this peritrochanteric space can be surveyed. If you want to go to this video, this is the YouTube link which I am sharing here. You can watch the video to get a clear idea. Some references which you can go through. So students, thank you for watching this video, and I hope this video will help you in understanding the trochanteric bursitis. What is a bursa? We all know this, and then role of bursa is to reduce the friction and to so that the movements are smooth, and it acts as a cushion between the muscles and bones and tendons, reduces the friction, and when because of any kind of factor or an infection the bursa is irritated, it is inflamed, it is known as bursitis. And we have seen some of the basic things like the management and the pathology and the surgical procedures. So any doubts, please we can discuss in our Google Classroom forum or in WhatsApp group. Thank you.